Professor Makoto, thank you for talking to ecancer. Tell us about yourself.
I'm a medical oncologist from National Cancer Center Hospital East, Japan. My specialty is head and neck medical oncology. I take in charge of treatment of head and neck cancer more than 20 years. Yeah.
Gosh, and one of the cancers you have to look after is thyroid cancer.
Yeah.
And the common treatment for that is radioiodine?
Yeah, but initial treatment for different thyroid cancer is a surgery, but and subsequently receive radioactive iodine therapy as a luminant ablation or as adjuvant treatment according to risk of recurrence.
And we know, of course, that some of the thyroid carcinomas are resistant to radioiodine.
That's right.
So what do you do in your clinic in Japan in that situation?
Yeah, as you know, a number of cytotoxic drugs has been investigated. Several cytotoxic drugs demonstrated clinical activity, but limited response duration and considerable toxicity. Therefore, patients with radioactive iodine refractory DTC, until approval of VEGFR target TKI, have represented unmet clinical need. But recently, VEGFR target TKI, including sorafenib, lenvatinib, demonstrated a significant improvement of progression-free survival over placebo, leading to approval for this population. So now we can use these two drugs for this population.
Tell me about those two drugs.
Lenvatinib demonstrated a significant improvement of progression-free survival over placebo with hazard ratio of 0.21, and they extended the median progression-free survival by 14.7 months compared with placebo. That's a great benefit for patients.
And what interested you in the drug? Because you're always looking for new drugs. Huh?
This drug is treatment duration is very, very long. Only one drug. That is a great advantage. And also, the current study, we evaluate the impact of duration of drug interruption on the efficacy of lenvatinib in patients who enrolled the SELECT trial. That is a randomized clinical trial comparing lenvatinib or placebo in patients with radioactive iodine refractory DTC.
How many patients were in the study?
Overall, 392 patients were randomly assigned to 2-to-1 ratio to lenvatinib or placebo.
That's a big number of patients.
Big number.
You have a big, busy clinic. And then the data was opened and looked at when?
Yeah, the primary result was already published in New England Journal of Medicine, and there are a lot of subgroup analysis was also published. Yeah.
And the evidence is clear for the survival benefit. What about the side effects, and what does the patient feel, and is this tough going?
Yeah. Most common grade 3 adverse event included hypertension, decreased appetite, and decreased weight and proteinuria. But most of toxicity was manageable by dose modification or drug interruption. So I don't think this drug is manageable.
And the patients complied?
Complied.
And they continue to go on?
Yeah, that's right.
What happens when you interrupt the drug? You delay by a while, or you change the dose? Or?
Yeah, some patients need dose reduction, but some patients need to keep the dose. Because during the dose reduction, some patients develop disease progression. So dose intensity is very important to keep the treatment.
And you did some subset analyses. Is that too early to talk about that?
Yeah, okay. Multivariate analysis indicated that duration of drug interruption is significant factor in efficacy of lenvatinib.
Okay, so you have to be careful about that.
Yeah, that's right. Also, Kaplan-Meier curve, according to duration of drug interruption, demonstrated progression-free survival is better in patients who had less than 14 days of drug interruption than that of patients who had longer drug interruption.
So, what's your advice to other head and neck specialists all over the world who will be watching this video?
Results from our study indicated that long period of drug interruption may negatively impact potential benefit of lenvatinib. So we have to reduce the duration of drug interruption, and also when adverse event becomes severe, patient quality of life worsen, leading to drug interruption or treatment discontinuation. So I think to reduce the severity of adverse event, both early recognition of adverse event and appropriate management of toxicity are essential.
And you think now that this is the drug of choice for the treatment of radio-iodine resistant thyroid cancer?